welcome Peter Mendel and Sean Mann for joining us today. As Jamie just explained, this is something that we've introduced earlier this year. Want to get thought leaders to come and help us open our own minds here, because sometimes we in government can be in our own little bubble, and we all need to take some time and hear from leaders like yourself, experts like yourself. So with that, I'm going to let you start with your presentation. Once the presentation is done, as Jamie said, we will be opening the floor, virtual floor, for questions. And of course, I have some questions too for you, because given your background in science and technology and research, there's a lot we need to learn. And having said that, back to you, Jamie.
Great, and we'll turn it right over to Peter to kick us off. Thanks so much.
Okay, well, thank you, Jamie, and thank you, Gopal, for inviting us to present. We're very happy to present and discuss the machine learning methods we used in our congressionally mandated study on federally funded health services and primary care research. As Jamie said, I'm Peter Mendel. I'm the PI of the project, and Sean Mann, who will actually be presenting the bulk of the talk, developed and led the machine learning analysis for the study. And I also just want to say it was and still continues to be a real pleasure for us at RAND to work with Jamie and the rest of the AHRQ team on the project, and make sure that when we applied these methods, we did it in a very meaningful way, and I think in a way that really turned out to be the only approach that could solve the research questions, or at least a set of the research questions that we needed to. And through that, we went down this path of applications that have been used at RAND and other places, but really fine-tuned it and tailored it to the particular research question. So we're very happy to present the kind of journey we went through and the details of that method. And if, Sean, you could go to the next slide, advance. And if, there we go, great, thank you.
I think Jamie might have control rather than me.
Oh, okay, Jamie, that would be great. So here's the outline of our presentation. I'm going to give a very brief overview of the study, given that many of you have probably seen the report and also heard Jamie's presentation on the study before. And then I will pass it on to Sean, who will review background on machine learning methods and purpose and why we chose the methods, our application of machine learning to the HSR-PCR study, and our reporting of results. And we're planning to talk for 35 to 40 minutes to leave enough time for your questions and discussion at the end. Jamie, next slide. Thank you. And so here's the overview. You could advance one more. And as you probably know, Congress authorized AHRQ to contract for an independent assessment of federally funded health services research and primary care research. And the study's objectives were to assess HSR PCR portfolios funded by federal agencies, to identify potential areas of overlap and research gaps in those portfolios, and to recommend strategies to improve outcomes, value, and impact of federal HSR and PCR over the next 5 to 20 years. So very forward-looking. If you could advance to the next slide, please. So we used 3 primary data collection methods to address the study questions. The first was environmental scan and portfolio analysis, which used the machine learning methods. We also formed 2 technical expert panels, one for HSR and one for PCR. And we also conducted 50 stakeholder interviews to cover a wider range of perspectives. And if Jamie, you could just click once for the text on the bottom. Yes, and so the scope of the study covered all operating divisions within HHS, as well as the VA's Veterans Health Administration, and it also included research grants and contracts between fiscal years 2012 and 2018. And Jamie, if you could advance. And we found the 8 federal agencies that funded HSR and PCR according to the definitions of our study. And we were able to collect systematic data on research projects for 6 of them. So if you could just click once, Jamie, and then you'll see those are the 6. If you could advance to the next slide. And as I mentioned, we use the machine learning methods for the environmental scan and portfolio analysis, which we'll be focusing on today. This task had 3 goals: to generate a conceptual framework of the federal HSR and PCR enterprise, catalog a database of federal HSR and PCR funded projects, and then, of course, to analyze the breadth and scope of the federal HSR and PCR portfolios. If you could advance to the next slide. And in terms of the conceptual framework, we realized that and recognize that HSR and PCR are overlapping but distinct fields. And thus we used distinct definitions for both of those. If you could advance the next slide, please, Jamie. And we also derived a framework of research domains within HSR and PCR, which included 4 domains for inputs to healthcare, 4 domains for outputs of healthcare, and development of different types of research methods and tools, as well as a set of special drill down research topics. I believe overall, oh, you can stay on that slide just for a second, Jamie. I believe overall, we had 20 different research categories, including the ones that you see here, as well as the different methods and tools development categories, and of course, the HSR and PCR distinctions. So now I'll hand it over to Sean, who'll go into more detail on the machine learning approach and methods we used in the study. So Sean, please.
Great.
Away.
Thanks, Peter. And Jamie, I'll also ask you to advance slides. If at any point my internet cuts out, I am getting your audio pretty good, so please just let me know. I can join using the Zoom app on my phone, hopefully. But hopefully it'll stay good this whole time. So the bulk of this presentation, like Peter said, is about our machine learning methods that we used for our environmental scan. Here's an overview of our analytic strategy for our environmental scan. And there were four kind of main steps that we took. We collected the data. We had data from 2 sources. We had just over 1,100 records. And in our case, a record was a project description, a specific federally funded research project focused on health, and that we wanted to determine fit any of these 20 categories of our research domains, including overall, is it health services research or primary care research, and so forth. So we had 1,100 project descriptions, including contracts that we got directly from agencies, including from AHRQ. So a fair number, but the vast bulk of our data set, at least by numbers, was a set of just over 92,000 project records from NIH Reporter. NIH Reporter is the kind of source of record for federally funded health research, covers the HHS agencies as well as the Veterans Health Administration. Lots of these projects were from NIH, but others from AHRQ, CDC, and other agencies as well. So in total, we had just over 93,000 project descriptions that were within the scope of our list of agencies we were covering in the environmental scan, and that were within our kind of time period scope of 2012 to 2018. So it's a large number. The next step in our analytic strategy was we reviewed a sample of these by hand. We knew we could do a bunch, a few thousand, but we also knew that we weren't going to be able to actually have human eyeballs on 93,000 separate project descriptions, decide for 20 different categories, does it fit this category or not for each of those 93,000. So in order to actually make our analysis feasible, we enlisted computer support. We sought to automate the review of the remaining data that we weren't going to be able to manually review. We used a machine learning algorithm for this. That's what I'll be discussing in most of this presentation. And in the end, we combined the results from our manual reviews and then from our kind of automated reviews using the machine learning algorithm of the rest of the data set. And we got our kind of agency by agency, year by year portfolio breakdown of how many projects were health services research, were PCR, fit each of our other 18 categories and research domains. So that's the broad overview. I'm going to jump down first to the manual reviews, and then the rest of it will focus on the machine learning algorithm and methods. Thank you, Jamie. So for the manual reviews, like Peter said, this is where we use the research domain framework. This is a qualitative effort. We read an individual project description, 1 to several paragraphs long, and then we're kind of decided, does that project description, does that fit our formal definition of HSR and PCR or any of our other categories? For each of those 20 categories in research domains, we developed a formal definition. We developed various inclusion and exclusion criteria. It wasn't always 100% clear whether a project description would exactly fit the definition of one of these categories, but we tried to formalize this kind of qualitative classification effort as best we could. There were 4 of us in total, including Peter and I, who reviewed project abstracts. We spent many days doing this. Having multiple reviewers on the study team, one of the benefits of that was that we were able to have multiple reviewers look at the same projects in many cases. We took out a random sample of the project descriptions, and I or Peter or another reviewer, a couple of us would independently on our own look at that project description, classify it as yes or no for each of our 20 categories, then come back together, compare our classifications. We could measure how much we agreed. We could refine any of our definitions or rules, at least early on, while we're still in the formative process. And then we also discussed discrepancies and reached final agreement on any projects for which we had disagreements by consensus. We measured the level of agreement for each of those 20 categories using this multiple reviewers that looked at a random sample of projects. And we had the full results are reported in the appendix of our report, but just an example, we had over 90% agreement on what was or was not health services research and what was or was not primary care research. In general, conceptually simpler and clearer categories like, say, pediatric research, we agreed more often than more conceptually up for interpretation categories such as access to care, where it might be a little less clear looking at a project description. Is this exactly talking about that subject or not? We, in the end, reviewed around 3,000 of the projects in our data set. That included all 1,100 plus projects that were provided by the agencies as identified by them as likely to be in scope of our environmental scan. It also included around 2,000 project records from Reporter. Some of these were we selected purposely as most likely to being kind of in scope of our environmental scan, HSR, PCR, or methods and tools development. But a large portion of these were also selected randomly from the full Reporter data set in order to be representative of the remaining data that we hadn't reviewed. So we still had 90,000 projects left to review after reviewing these 3,000 manually. And that's where the machine learning comes in, of course. Before I jump in to exactly what we did, let me just provide a brief overview of machine learning, what it is. It's a kind of automated, computerized process that's often used to automate the types of tasks that we were doing. We were calling a classification task, taking some input data, in our case, project abstract. It could be any kind of input data, imagery, other types of numerical or other input data, and teaching an algorithm to learn patterns from that input data, to encode patterns, and to code those patterns into a computational or statistical model, and then finally using that model with those patterns to analyze new data and make predictions or make decisions about that data to interpret it in some way. So there's lots of different applications of machine learning. I'm actually working on a systematic review for the Patient-Centered Outcomes Research Institute, PCORI, on all clinical applications of machine learning that are currently in use today. Some examples of those are, there's a lot of image interpretation tools that use machine learning to aid in diagnosis of cancer or traumatic brain injury from whether MRIs or X-rays or ultrasounds. There's programs that run within electronic health records to try to, say, identify hospitalized patients that are at risk of severe sepsis in order to flag them for care escalation. There's a lot of use of machine learning in research and development around health, whether in streamlining the process of identifying published research for systematic reviews, a lot of applications in drug discovery, even in, for regulators or healthcare payers, number of applications that they can use to identify, say, suspicious patterns in claims data in order to flag potential fraudulent claims. So those are some examples. Turning back to our specific use of machine learning in the environmental scan, if you can advance the next slide. And one more. Great. So we followed kind of 4 specific steps in operationalizing our machine learning methods. We wanted to turn the text, our project abstracts, into data that the computer could then interpret. We needed to develop a model in our machine learning algorithm and train it, in our case, using the manually reviewed data. We needed to validate that model to make sure it could confront all the new data that we hadn't yet manually reviewed and produce valid answers about it. And in the end, we needed to apply that to the entirety of our data set and compile our results of how many projects for each agency in each year fit our definitions for our 20 categories. So I'll go through each of these one by one. First, turning text into data. This is often called natural language processing, where natural language refers to any textual representation of language as written or as spoken. In our case, it's 1 to several paragraphs in a project description. We used a relatively simple model for taking this text and turning it into data called a bag of words model. It's kind of like you took the entirety of that project abstract, split it up into each of its individual words, threw all those words in a bag, shook it up, and then looked at what was in the bag. How many words of what types were in that project abstract, and then trying to associate that with the final answers of, was this project HSR or not, or PCR or not. One of the steps in this process was selecting the exact words or phrases we were going to include in our input data. We weren't going to include every single word in the English language. We actually chose just the 2,000 most common words across all research abstracts to include. And we also, right before that, we removed words, what's called stop words, that are kind of words that we know do not carry much meaning: if, and, but, the, so forth, and just stripped those from the abstracts, counted up the most frequent words, and then we assigned values, having selected those 2,000 kind of most commonly showing up words and two-word phrases in the abstract. We assigned each of them a value for every single abstract. That value was based on two things. First, we counted the number of times a specific term showed up in any given abstract. So pretty simple. Oftentimes it was 0 if one of those words didn't show up in one of the words in our list of 2,000 didn't show up at all in an abstract. That also carries meaning. We want to learn patterns related to the absences of words as well. And then we took that count of the frequency of the term showing up in an abstract, and we divided it by the number of times that the term shows up in all abstracts. This is called term frequency inverse document frequency weighting. And the reason for that latter step, dividing it by the number of time a term shows up in all abstracts, kind of embodies the intuition that a particular word that shows up in almost all project descriptions, say the word research, it's probably not going to be very meaningful or discriminating in actually distinguishing between whether that abstract is HSR or not, as compared to a word that shows up, say, in 5 or 15% of abstracts, like opioids or safety. So words that show up in some abstracts are weighted a bit more. And we were going to, we now having this list of all words in each abstract and these values assigned to each, we then go into our next step of training the model. So our machine learning model was we use a logistic regression model, which is a relatively common statistical model for taking input data of various types and answering kind of a yes or no question. In our case, is this primary care research or not, or any of our other categories? This model took that list of words and phrases in each project abstract as the input data. It learned to associate each of these words and phrases with from the manual review data, which we had already categorized certain abstracts as HSR or not, and to associate the words that were in abstracts that we did find to be HSR. Those are going to get higher coefficients associated with that particular domain, say HSR or patient safety. For an example, for the primary care research category, some very positive coefficients were given to some words you'd expect, like primary, opioid therapy, or hypertension. Some very low coefficients or negative coefficients were given to words like hospitals or surgical. Small coefficients or neutral coefficients were given to other words like protocol or EMR. In the end, the regression model outputs a probability score from 0 to 1, kind of predicting whether or not that project fits a particular research domain category, whether or not it's PCR. We'll discuss what we do with that probability score in a moment. We also sought to validate this model. There is a potential problem, particularly when you have a large number of input variables, and we had 2,000 words and phrases we included, so a pretty large number, that a machine learning model can overlearn patterns that are very specific to the training data set of manual reviews, in our case, that it was learning patterns from. If it is overfitted, the model can maybe reproduce the correct answers on the training data that's already seen and learn these patterns from. But when confronted with new data, it's much less accurate. So we wanted to make sure that it was actually just as accurate when confronting new data. To address this problem of overfitting, we adopted what's called a cross-validation approach. We divided the manual reviews, the 3,000 manual reviews we did, into training and testing sets. 80% of these reviews we trained the model on, and then 20% the model hadn't actually seen before. Confronted with them, the model would then make its own predictions, and then we could use the predictions on that 20% of the testing projects to measure the accuracy and make sure it actually is producing valid results. We did this 5 times for each of the 20% chunks of our data set as part of our cross-validation effort. Before I get into the final step of classification, just briefly on measuring accuracy, we used kind of sensitivity and specificity as primary measures of accuracy, fairly commonly used in the health domain. On the right, this is a confusion matrix or an error matrix. It shows the association between the actual manual reviewed positives and negatives for each category, in this case for primary care research. And these are just notional example numbers. And it shows those and how they relate to the automated results from the machine learning algorithm. In this case, if you look down the columns, at the bottom, there's 430 projects that were manually reviewed as PCR and 2,150 that were found to be negative for PCR in the manual reviews. The machine learning algorithm accurately in the upper left quadrant classified 400 of those 430 actual PCR projects. It classified them accurately. It recognized them as true positives for PCR. It missed 30 of them. Those are 30 false negatives in the bottom left. On the other hand, in the bottom right, it accurately classified 2,000 the manually reviewed projects that were not PCR, but it produced 150 false positives where it took a project that wasn't actually PCR and it thought it was. So it lets you know your errors. In our case, the sensitivity here, the true positive rate, is the number of true positives, 400 in the upper left, divided by the number of actual PCR projects or positives, 430, it's 93%. Specificity is in our case, 2,000 true negatives identified by the machine learning algorithm out of 2,150. In this case, it just happens to be also 93% kind of for illustrative purposes. I'll be referring to these measures in the next slide. And 2 examples for how we selected the threshold that we're going to use to actually turn the probability scores, the output of the machine learning model, into actual classifications for each project, yes or no, are you PCR? So here on the right, there's 15 projects shown. There's a raw score, a raw output of the machine learning model from 0 to 1.0. Obviously, projects that get a score of 0.97 are probably going to be counted as PCR. Projects that get 0.06 are probably not PCR. But there's many in the middle, around 0.55, 0.59, 0.43. And it really matters where you select, what cutoff point you use, above which you're gonna consider a project to actually be PCR or not. With a threshold of 0.5, have a naive threshold right in the middle, you might have this set of 9 projects classified as PCR. And that might correspond across your entire data set to the same numbers that we saw before, with the 400 true positives, the 2,000 true negatives, sensitivity of specificity of 93%. If you actually add across, however, And we're looking to get valid kind of population estimates overall. How many projects in this portfolio are PCR or not? We're mostly interested in the total that are going to be classified as PCR or not. And you can see here, there's an addition error that in this version of the slides. Sorry about that. It should be 550 on the right instead of 650. But 550 is the output of this machine learning model. That's how many PCR projects it found. The actual number was 430. 550 compared to 430 is actually off by almost 30%. Even with a sensitivity and specificity of over 90%, our end answer of 550 projects that are PCR is actually off by a fair bit. Another option, we actually tried out a whole bunch of different thresholds. In the end, we sought to pick a threshold using a cost balancing approach. We wanted the number of times we were wrong in one direction, false positives, to roughly cancel out or equal the number of times we were wrong in the other direction and produce false negatives. With, in this example, with a threshold of 0.8, the sensitivity goes down. It's a little harder for a project to be classified as positive for PCR. In this case, we only identify 360 out of the 430 PCR projects as accurately being PCR. But we're a fair bit more specific. We have a specificity of 95%, recognizing 2,080 out of those 2,150 projects that weren't PCR correctly. And you see that the number of false negatives and false positives actually ends up being the same at 70. With our end answer, our estimate of how many of these projects are PCR from the machine learning algorithm being 430 on the right, which actually ends up in this case being the right answer. So we chose our threshold using kind of setting an equal cost to false positive and negatives, and then seeking to balance those costs against each other. We then took the manual results, the gold standard answers that we had for 3,000 of the projects. We took the machine learning results for the remaining 90,000 projects and added them up for each of the agencies. We just for all 20 categories. I don't have the full results in this slide here because there are a lot of them, but they're of course highlighted in the report, and reported how many were in scope of our environmental scan, how many were HSR, PCR, and how many of those, what percent fit each of our categories of interest. So we, for example, we found out of the 80 some odd thousand NIH projects, we actually found 6,900 of them to be HSR or PCR, while other agencies like AHRQ, which have a much higher percentage of HSR within its overall portfolio, but many fewer projects, we found 668. I'll leave it there. We do have the full results in the backup section. And we did actually, because we had run this multiple times as part of the cross-validation step, we were able to produce rough confidence intervals around each of these numbers. And overall, our estimates were pretty tight, regardless of what training data we used. Around that top line number of 8,845 total projects that were HSR or PCR. It was just a couple hundred on either side within the 95% confidence interval. So relatively little error in the end. We did report accuracy as well, and those are also reported in the results in terms of how accurate the machine learning algorithm was. But I'll leave it there for questions or comments.
Thanks so much, Sean and Peter. I've got, let's see, I've gotten a couple questions. If there's any others, please feel free to send this. So I'll ask a couple that somebody texted me. You mentioned that there are some other examples of how RAND is using AI in other studies that you're doing there. And so the question was the HSR or PCR report the first attempt that you had to do this, and what were the strengths and limitations of using this for whether this particular project, or what was the most kind of surprising thing that you learned while doing this study as it relates to this approach?
Happy to answer those. On the first question of what else has RAND worked on using machine learning, actually a fair bit. I haven't been a part of many projects, but a RAND, a longstanding RAND effort has been looking at the Affordable Care Act and other policies relating to health insurance markets, and using historical data on a month-by-month basis to be able to predict how insurance coverage will evolve over time, might change if the state decides to expand Medicaid or not. And that's one example of a project that RAND has used machine learning for. Perhaps a little more similar to this one, which was looking at text and classifying it in different ways. RAND has looked at tweets, election-related tweets, and tried to classify them as kind of more likely to be from an actual person versus, say, part of an organized disinformation campaign. There's a lot of social media applications that people have done at RAND. And there's really just a lot of ways you can use machine learning. To get the second part of your question, limitations, one of the biggest limitations is the computer algorithm, the machine learning algorithm can only be as good as the input data that goes into it. In our case, the clarity with which we kind of defined our categories of what is HSR or PCR, the degree of consistency that we had in our manual reviews, being conceptually clear and having a high level of agreement, and actually generating this data which we use to train our model, that was kind of the foundation for any level of accuracy for the model itself, because it can't be any better than the input data. You certainly have problems of bias potentially, say with machine learning in healthcare models. If a machine learning model is trained on data relating to, say, patient health outcomes, and the population of patients used is not representative of, say, minorities, then the predictions it makes when confronted with new data from patients that are in underrepresented groups, they may not be valid, it may not be generalizable. There can be bias baked into the algorithm based on the input data. So that's one of the largest limitations of this approach.
Yep, that makes sense. So I have two other questions that are coming in, and then I'll turn it over to our director. But one question was, did you include any n-grams in your models?
We did. We included bigrams, or two word phrases in our models. Tested it out with 3-word phrases as well, but it did not really improve accuracy. Also tested out with any phrases, but there were a number of phrases that were meaningful. So that means we both included individual words, as well as if a particular phrase, such as primary care or opioid therapy, showed up frequently, we also included those 2-word phrases in our input data.
Thank you so much. Gopal, I'll turn this over to you for a moment.
Thank you, Peter, and thank you, Sean. That was a very insightful presentation. Hopefully my colleagues have gotten a lot of a deep dive as to how you've used machine learning and AI to to create this report, which has been extremely meaningful and useful for us, particularly as we look into the future. So let me move away from the RAND report now for a second. And Sean, given your experience, and Peter, give me a sense as to what's happening with the AI and machine learning in general. Of course, these are not new technologies. They've been used by Google, Amazon, Apple, as they've built their own platforms. And early on, over the last 5-7 years, there has been a very slow adoption of this technology. Certain industries have been ahead of us. Banking, insurance companies, and others have used AI more extensively. And even at one point, IBM had to change AI from artificial intelligence to augmented intelligence, because folks in the healthcare sector, particularly physicians, objected to the fact that what is this artificial intelligence? Why are you going to use machine to diagnose people? So how are you seeing the ubiquity and fidelity of these technologies in the healthcare sector?
Yes, let me say also that you're right. They're becoming more ubiquitous, but it's been a slow learning curve, and I think that slower adoption is actually a good thing. If you get anything from the presentation, especially as Sean showed, all the decision points that have to go into doing the analysis and ensuring that there's not bias and all that. Requires a lot of thought. So a poor application of AI can yield actually, in some cases harmful outcomes too, as well as Sean was mentioning, and this is also coming up in kind of the general public too, talking about the biases in AI and how that kind of generates certain inequities or disadvantages to different people. I think also because, when banks use it or Google uses it, a lot of times it's for internal consumption. It's not that in healthcare, there's some, especially in clinical applications, there's, there can be, it's the health and, well-being of individuals. It could be life and death, and as well as it kind of healthcare services and improvement. We want to be improving and not in the right way, and not just changing based on algorithms. So thoughtful uses of algorithms. It's easy to, it's a very powerful tool that can come up with answers very quickly. But at the same time, if we don't understand how we're using the tools and decisions that are made using those tools, then there's a real problem. At RAND, there has been also an explosion of the use of the tools, but also really understanding, and not only in using them, but as being consumers in understanding the outputs of those algorithms.
Peter, I couldn't agree more, because our work is such that it's all about science of delivery of care. So we have to be extremely careful. And you're right, that's the reason why healthcare industry has been slow in terms of adoption. However, are you in the industry, in the healthcare sector, seeing new use cases? And I'll give you an example. 2 years ago, my colleague, Dr. Jeff Brady, and we all talked about artificial intelligence use case, particularly for X-ray and for diagnostic analysis, right? So reaction had from some of my colleagues at the department was, no, it'll be objected upon. And finally they warmed up, and now they're saying, it'd be a good use case to see how we can use AI for particularly diagnostic error, and it's drilling down particularly X-rays and lab test results. So my question to you, are you seeing use cases in the healthcare sector, particularly on the delivery of care?
First to plug, have a report coming out about this in probably 5 or 6 months, published by Picori, looking at this exact question. There's a lot of applications using imagery in diagnosis of cancer, other conditions. We found just a couple dozen that were approved by the FDA that didn't use imagery. There's kind of, there is a wide range, there's a lot of development. There's thousands and thousands of academic efforts that test a particular algorithm using some input data, but they're far from actually being used, as you mentioned. That it's much more, there's a lot more early research than actual implementation. We did find some very interesting use cases, a whole lot of promise, particularly around, say, identification of severe patients at risk of severe sepsis. There've actually been a couple of RCTs that have found very, very dramatic decreases in mortality for patients in the ICU when care is escalated based on machine learning predictions. But there's certainly, in many of the fields, a lot more hype than actual implementation. All the FDA approved applications that we found were all kind of class 2 or moderate risk. There's a couple in the pipeline, including insulin pump or artificial pancreas that would kind of be higher risk, kind of under the most stringent regulations as class 3 devices. They haven't actually been used in the broader population. They've just been studied in kind of clinical trials so far. So imagery is a lot more developed. There's also interesting work under kind of mental health therapy, medication adherence reminders that are built around machine learning, a lot of other fields, but I think there'll be a lot more in 5 years than there are today. And a lot
No,
of
course, I agree with you that
is being developed.
Yeah, sorry.
Too. Oh, sorry.
No, I agree with you, Sean. There has got to be a maturization cycle where it has to be matured enough. But the question to you then is, yes, there was hype 10 years ago. AI is coming and what the magic will be and the world's problems will be solved. But are you seeing enough maturation in the development of technologies that it's at a point where one can, at least in a test mode, not in applied situations, start looking at initiatives or projects or some research projects that can help prove or identify improvement opportunities? Do you see any?
We found 175 evaluation studies of AI applications in the scope of our report for PCORI. Some of these were much lower quality than others, but a number were peer-reviewed, randomized controlled trials. I think one way to get at your question, looking at the coronavirus crisis, there's a lot of efforts to try to develop machine learning applications to do everything from triaging patients, presenting at a hospital based on various data inputs to see what level of care they might be triaged to, predict risk of respiratory failure, and so forth. But there's been not that much implementation, at least on the scale of just the 7-8 months or so that we've been undergoing this. There's been, even with all this attention, there's been very little that has actually been implemented in practice. So there are some kind of interesting research studies that are ongoing to address this. But there are a number of peer-reviewed studies. All 175 of the ones we identified are going to be in our report for PCORI. But there's a number of applications that are out there that really haven't been evaluated, at least in the published literature. And it certainly could use a lot more evaluation to determine exact level of patient benefits, as well as any kind of follow-on effects in terms of clinician workflow, in terms of patient-clinician communication and trust, and whether it has impacts on those other aspects of care.
Makes sense. Sean, one of the things, sorry, go ahead, finish your thought.
I was just going to say, if I could add also, this is all juxtaposed against the real strength and opportunity that all that hype for AI was for, because, and so I think it bears, and it warrants real effort and focus from federal agencies to really push how this, how these technologies can be used and to get it out there safely and usefully, because its ability to, it can be very quick. It can review, let's say, clinically, many more x-rays much more quickly than you could by doing, audits, by individual radiologists or technicians. So it has the potential to really scale up, and AHRQ is all about scaling up improvements, to really scale up and use, and now that we're getting into the learning health systems, use all that data and mine all that data in a way. And I think the main part about doing that, one is, I think the advantages seem to, there's enough opportunity and potential there to have it, but to use it and think of it as a tool that will require the human intelligence to train it, but also the human intelligence to validate, ensure that it's being used properly.
So Peter, coming to something that you just said, one of the things that is happening is that Representatives Upton and DeGette several months back put out an open letter saying that we want to think about Cures 2.0. And as you know, that Congress gave the country the 21st Century Cures Act that helped bring new technologies for new discoveries. But the way we at AHRQ see Cures 2.0 is we see it from the point of view of 21st century care, because cure and care are two sides of the same coin. So having said that, the pressure or the ask of us is define 21st century care. And the way I like to define it is in the digital space. We live in the digital age. COVID-19 has really disrupted the current delivery models at all levels. And some of them changes are irreversible. There'll be new ways care is delivered in different settings, not just using telehealth, but other technologies, devices, 24/7 data flow, et cetera, et cetera. So having said that, the fact that our researchers are our brain trust, they have been the ones who come up with new ways of looking and answering difficult questions or new questions. So part of AHRQ's work is research, a big part of it. How do you see AHRQ playing a leadership role in that, in that shaping of the 21st century care?
Well, I will say AHRQ certainly is in the position and is the leader in understanding what 21st century care looks like and bringing an understanding of how, one, these things can be applied to healthcare as opposed to clinical, but also in the clinical applications, how they can be scaled up in a way that improves health, as opposed to creates more chaos, right?
Yes.
Standing. And so there's a real opportunity for AHRQ to be a leader in that. And people are looking for that. In the HSR PCR report, that's what we found when stakeholders look to AHRQ to help define that and expect AHRQ to play that unique role.
Well, this has been a very energizing conversation. We can talk more about it, but I'm looking at the clock over here. Jamie's just appeared saying that Gopal, it's time to say thank you. So thank you, Peter and Sean. I appreciate your being here. And again, this conversation continues, and thank you again.
Thanks so much.
Thank you.
Thanks so much,
Thank
Peter
you.
and Sean. We've enjoyed this conversation, and I look forward to working with you again in the future. Thanks again.
Yes, thank you so much for having us.
Thank you, our colleagues, for joining us. Have a great day.